Our guest is a consultant hematologist who has had plenty of experience in implementing this new protocol first approved by the FDA back in 2018. Thank you so much for joining us today, Dr. Binyam.
Hi, Zahran. How are you doing
Hello.
today?
I'm good, thank you. How are you?
Very good indeed.
That's great to hear.
So it must be quite cold out there in the UK now because I'm speaking from Saudi Arabia.
It is, yeah.
The
Is it cold in Saudi Arabia still?
the winters are really nice here. We got temperatures between 20 to 30 here
Yes.
in the winters in the western coast.
Yeah, here that would be boiling hot. But yeah, let's proceed, shall we? And I would like to know first of all, if you could tell us more about your background and successes.
So I am a trained hematologist. After completing my medical degree from India, I went to the UK where I did postgraduate training. I got my CCT from working in and around Cardiff, and I worked as a consultant post my CCT in Cardiff for 2 years before moving on to Saudi Arabia in a city called Jeddah. So that's where I'm currently practicing for the last 5 years.
Thank you very much. And let's begin on the topic of conversation. Could we please learn from you what chronic myeloid leukemia is?
So, as the name would indicate, it's a chronic disorder and it is a leukemia, which means there is an uncontrolled increase in the number of the white blood cells in one's body. So a cancerous mutation happens somewhere in the production line of the white blood cell, or the cell with the mutation keeps multiplying itself, and multiple copies of this cancerous cell is then produced. So with time, it turns into a full-blown leukemia whereby you can see uncontrolled number of cells in your blood if you did a blood test. So this is chronic myeloid leukemia in a nutshell, and it because it's chronic, it's a slow progressing disease,
Yes.
uh, unlike the acute variants of leukemias. One more point I would like to add is the natural history of the disease is that if you leave the disease untreated, eventually, after a few years, it will turn into an acute leukemia, which is more life-threatening than the chronic version.
And would that be the progression to the blast crisis, where only
That
blastocytes
is
are used? Yeah.
that's correct.
Ah. And please, could you tell us what are tyrosine kinase inhibitors, please?
So there was a revolutionary treatment that became available in uh, the early part of this century. So around 2000, uh, there was a discovery of a medication called imatinib.
Yes.
The trade name at that time was called Gleevec. It was one targeted molecule which would switch off the cancerous changes and then reverse the process of chronic myeloid leukemia without affecting the other cells and tissues of your body as much as the traditional chemotherapy would. So if you were to imagine, traditional chemotherapy blasts everything that comes in its way. That's how it kills cancerous cells. So there is a lot of side effects associated with traditional chemotherapy. You may know the common ones, the loss of hair,
Yeah.
and infections and organ damage and so on. But when it comes to targeted therapy, basically it just attacks the cancerous cells with the mutation and very few collateral damage. So tyrosine kinase inhibitor was the first of its kind in any branch of medicine.
Yes.
It was the first targeted molecule, and it would work against the specific mutation that happens in CML, which is BCR-ABL fusion protein, which happens as a result of a translocation between 9 and 22 chromosomes.
Yes.
And tyrosine kinase, once it came into the market, has changed the landscape of CML treatment. Previously, CML was a deadly disease. The only way to cure people with CML were to give them intensive chemotherapy followed by an allogeneic stem cell transplant. This was not an easy procedure to do because many people were not fit to have the transplant. And even if they did manage to get a transplant, the transplant-related mortality was very high. So
Right.
Again, TKI therapy was a groundbreaker in this aspect. So we managed to change CML from a deadly disease to more of a chronic disease with TKI therapy.
Okay, thank you. That was very detailed. And now on to the updates. What is TKI discontinuation?
Right. So we in the medical field are always looking at how can we improve the lives of people who develop these cancers. So we are getting greedier in the sense that if we can control the disease and make it a chronic disease with TKI therapy, can we actually stop the TKI therapy if they were to get a very deep response or a good response? This was the question asked by a specific trial called the STIM-1 trial, which was done in 2010, which is Stop Imatinib trial or Stop the TKI trial. And the trial showed us that about 40% of people who are in a deep molecular response after using TKI will remain in remission even if you stop the medication. So those people who respond well to TKIs, if you take all of them and then stop their medication, about 40% of people will continue to remain in deep molecular response without needing any treatment. The other 60% will have to go back on the medication. But it is 40% people without needing any treatment or achieving a cure.
There were also other studies carried out, such as the Destiny trial as well, wasn't there? Is there anything that you know about that trial?
Yes. So there have been multiple studies which have followed the STIM-1 trial, and all of them kind of agreeing with the concept that TKI can be safely discontinued in a significant proportion of people who achieve deep molecular response.
Yes.
The ones who lose the response after stopping the TKI can regain the response after restarting the medication. So there is really nothing for the patient to lose by stopping the medication because they will invariably achieve a second deep response. Destiny trial was a UK-based trial that was done, which has improved the figure that I quoted earlier. So when I mentioned 40% or around 38% of long-term treatment-free remission, Destiny trial actually improved one step by changing the strategy slightly. In the previous trials, the strategy was to stop the TKI after a certain, conditions were met. But when they stopped it, they would stop it completely. So if somebody was on imatinib standard dose of 400 milligrams, they would stop, and then from the next day, it would be 0 milligrams of imatinib. But in the Destiny protocol, what they did was they took all these people in deep molecular response and then reduced the dose from the standard dose to half dose for 1 year. Now, this could mean that the imatinib dose could be reduced from 400 to 200 milligram, continued for 1 year, and then stopped. Similarly, if they were on a second generation TKI, such as dasatinib, on a standard dose of 100 milligram daily, they would reduce it to 50 milligram daily for 1 year and then stop. Now, the results were very impressive with the Destiny protocol because about 70% of people remained in treatment-free remission until the median follow-up on their last update. So this is an improvement over the previous studies, which showed around 40% success rate.
Right. Thank you very much. And now, in the first place, why is this being considered as a form of therapy? I know that you referred to it to be used as a way to minimize resources being used up. But are there any disadvantages to using TKIs?
Any medication has a risk of causing side effects to the people who use it.
Yes.
Not everyone does develop side effects, but there is a proportion of people who might develop life-changing side effects with it. And the idea is, if you don't require a medication, don't take it.
Yes.
Because we don't know what are the invisible effects that the medication is doing to tissues and cells in your body, whether they can give a long-term side effect. These are unknown things. So if we could avoid medications, we should. So the risk with people who stop TKI was deemed to be whether this will increase a risk of people progressing to blast crisis or accelerated phase.
Yeah.
And after 10, 12 years of multiple trials, we can safely say that stopping TKI is a safe business, and it doesn't increase your risk of transformation into blast crisis. And therefore, whenever we get an opportunity, when the people fit the criteria for stopping the medication, or in other words, in deep molecular response for a significant period of time, then I think we should give the patients the option to consider stopping the medication. Now, patients, I know of patients who would like to try and stop every single medication they are taking because they don't like the concept of taking medication. But there are also other patients who might say, actually, I'm feeling quite comfortable and reassured when I'm taking a TKI.
Yeah.
And so I would not want to stop the medication because my results are excellent. So ultimately, it's a decision made between the physician and the patient if the patient is willing to do this TKI discontinuation trial. However, we do have enough evidence to tell the patient categorically that it is a safe business. Even if the response is lost, you will get a second deep response, and things would be back to normal as before.
Right. And yes, this is a drug that people do take for the rest of their lives, or used to, until this update. And for a lot of people, it would increase their quality of life. And although on the other hand, there are people that would want to continue it, as you said. But yeah, with that option, it gives more patient freedom and autonomy and more ability to make their own decisions. So yes, overall, I think this would be very beneficial for patients as well.
Just to make one more point about what you said, some of the side effects that TKIs give patients, such as fatigue, is not really measured during routine clinic visits.
Right.
So patients are forced to live with this, and they're probably happy to do take the medication, accepting the fatigue or similar side effects, which are not really quantifiable, because they know that they are actually keeping the deadly disease at bay.
Yes.
But by stopping the medication, we could reverse a lot of these unquantifiable side effects, which will lead to a direct increase in their quality of life.
Right. Thank you. And we have gone over the benefits of being on TKI discontinuation. Is there any more you'd like to add?
Of course, there is no health system which can afford, costly health interventions such as the newer medications. So, cancer therapy is very costly. We are talking about, you know, TKI therapy costing up to like $100,000 in US per year at some point.
Yes.
The same Gleevec used to cost around 30,000 British pounds per year in the UK. But with the availability of generic medications, we have been able to reduce the cost modestly to, let's say, around like 8,000 to 10,000 pounds a year. But
Yes.
still, that's a lot of money that is being spent uh, on people who will take it for life. So the new CML patients who are diagnosed each year is actually joining the pool of people who have been diagnosed in the previous, 30 years.
Yes.
So the pool doesn't get any smaller. So the the health costs continues to increase exponentially each year. So I think whenever possible, if we can discontinue the TKI, that will be a big benefit for the healthcare system as well, uh, because then that money can be used on other areas of the healthcare system.
Yes. And this is how much the institutions are paying, isn't it? So in the US, the healthcare service is spending 100,000. Is that right?
That's correct.
Oh,
I mean, the second generation TKIs will cost more than the first generation, and the third generation would do more than the second generation. So
yes.
as the drug gets newer and more potent, the drug cost will increase. So the 100,000 figure is from what imatinib used to cost in the US.
Yeah.
Maybe it is more than that with the second generation medications at the moment.
Yes, and I'd imagine that patients in the US without insurance may also have to pay quite a bit per year as well.
That's correct, because there have been studies which have shown that people who do not have a good insurance tend to do poorly in CML, which usually would mean that they are probably not taking the medication
Yeah.
because they're trying to reduce, the cost by cutting it down to one every few days or whatever.
Yeah, exactly. And we have looked at the benefits of TKI discontinuation, and there are many, but are there any disadvantages to this treatment?
You mean to discontinue
Yes.
the medication?
Yes, to discontinue.
Well, the effect on the psychology of the patient is often underappreciated.
Right.
So we know from surveys that the physicians usually don't spend too much time offering help to patients who do actually feel anxious about stopping the medication.
Mm.
The support might not be there sometimes in a busy clinic. So these kind of issues whereby the patients might feel anxious and sometimes even depressed have to be taken into consideration. So that's why it is very important to make the decision in conjunction with the patient. Once that is sorted, the second thing is there is a syndrome called the TKI withdrawal syndrome,
Right.
which basically gives the patient who was taking TKI for a long time, after the discontinuation, they might get joint aches, basically. And the treatment for that is usually simple analgesics like paracetamol and ibuprofen. And with time, it just tends to go away. So within like months, this syndrome seems to just die out. But that is something to keep in mind and to warn the patients, because the patients, if not warned, they might come back after TKI discontinuation saying that something new has happened and this might be due to the disease returning. But in fact, it's because of the TKI being stopped.
And also, with any long-term effects, have there been any, like when on remission? Is there any long-term effects on the patients?
No, as far as the trials are concerned, they don't have any lasting damage by stopping the medication. So it's a safe, safe step to try and stop the medication. And if they remain in remission, so everyone is a winner.
Yes.
But if they do relapse, then we can restart the same medication and they will go into a deep molecular response like before.
Okay. Thank you very much. I would like to move on to your own personal experience when implementing this protocol. And first of all, I would like to ask how many CML patients roughly are currently under your care?
So I have about 60 CML patients under my care coming through my clinics.
Okay. And how many of them have you used TKI therapy on?
So virtually everyone have been on TKI therapy at some point,
Yeah.
all 60 of them. But currently, I have about 40 people on active treatment on TKI therapy.
Right. And have there been any instances where you did not implement TKI therapy?
No. So all of them received TKI, got a response. Just to mention, in case they do fail TKI therapy, then the only way to rescue them is through chemotherapy and allogeneic transplant. So
Right.
once in a while, you do see people doing that, but they all get TKI in the beginning. And out of my 60 patients, I managed to stop the TKI successfully in about 20 patients. So that would be around, I would say, 1/3 of them, or 33%.
Yes. And were there any common side effects that were diagnosed when your patients took TKIs?
So the TKI side effects usually depends on which generation of TKI it is.
Right.
Now, the first generation TKI, which is imatinib, is thought to be the safest of the TKIs, but the least potent. The second generation TKIs are more potent, but with more incidence of side effects.
Yes.
And the third generation TKI, or ponatinib, is very, very potent, but high risk of side effects as well. So it depends on what they are taking. But yes, I mean, there is a significant proportion of side effects seen in different people, but we usually manage it by either reducing the dose, giving them a treatment break, or changing to another TKI.
Yes. And you have said how many patients you have discontinued TKIs for, but how many have actually achieved a deep molecular remission?
So, generally speaking, if you had 100 people coming with CML in chronic phase,
Yeah.
and you were to give them TKI, you would expect between 40 to 50% of those people to achieve a deep molecular response.
Right.
And out of these people, let's say 50% achieved a deep molecular response. If you do treatment TKI discontinuation trial, another 50% of the 50% would succeed in remaining in remission long term.
I see. And
Or in other, yeah. So, or in other words, if you started with 100 patients of CML in chronic phase, you would be able to put about 25 people into um, treatment-free remission long term.
okay. Thank you. And how many patients relapsed after the cessation of TKIs?
So, out of all the people I tried, 20 people I succeeded in keeping them in TFR, and 10 people failed the TKI cessation trial. Or in other words, I tried in about 30 people who achieved DMR. Out of that, 20 were successful, 10 had a molecular relapse.
And did you observe any side effects because of this?
Uh, Out of the people who we stopped the TKI on, which is about 30 people, I had about 5 people having TKI withdrawal syndrome with joint pains and so on. So it is a small proportion, but it was managed with the simple analgesia and reassurance rather than anything more.
Okay. And how long on average were your patients on relapse before being discontinued on treatment again?
So what we do is once we stop the medication, we keep checking their blood for BCR-ABL copy numbers or transcripts every 4 weeks. As soon as we see that they have gone past the MR3 or major molecular response, we call it 0.1%. If they lose that, uh, uh, then we immediately restart. So most people who had to have a restart of TKI, it happened in the first 6 months. After 6 months, I haven't seen any relapses happening. So people who are destined to go back on the TKI, it happens mostly in the first 6 months. And we do it as soon as we see that they have lost major molecular response, we start it immediately.
Right. And are there any experiences that you have had with this particular protocol that you have learned from and would like to share?
So I think not many people, I think many physicians in the UK are following the Destiny protocol of reducing the dose and stopping. But there is nothing wrong in stopping it completely like before. But I think this reduction in stoppage increases, in my experience, the success rate. So I would recommend it to other people uh, to reduce the dose for 1 year and stop, like in the Destiny protocol. The other thing is a second TKI discontinuation is also possible. There are trials which suggest that if you fail it once, you go back on the medication and you spend a period of time in deep molecular response, you can attempt it again and you can still get successes of around 50% by doing that. So, there is no need to lose hope even if you have failed it the first time around.
Okay. And what percentage of patients that you stopped their TKI for stayed in remission at 3 months and also at 1 year?
So at 1 year, uh, there was 66% of my patients who I stopped TKI remained in remission.
Right.
So there was a success rate of 66%. And at
3 months.
3 months, it would be a little bit higher than that. Let me say about 75%. That's because between 3 months and 6 months, or 3 months and 1 year, there are some more patients who would actually relapse.
Right. And yeah, that would be variable when people would relapse. That would be dependent on what factors would you say?
We really don't know
Yes.
why some people succeed in these trials and some people don't. But we know from the previous trials that those who have taken TKI for a longer duration have a slightly higher chance of achieving the treatment-free remission. Similarly, those who have been in deeper molecular response, so when you measure the BCR-ABL transcripts, uh, you can categorize them into MR1, 2, 3, 4, and 5. The ones who are really, really deep, they have a higher chance of achieving treatment-free remission than the ones who are not that deep.
Yes. And I would also like to know more about your opinions on this new protocol. What do you think the effect on the quality of life of a CML patient is when taken off TKIs once the conditions are met, based on your anecdotal evidence and also maybe what you've read?
I think it does help people in the sense that once they know that they are continuing to be in remission despite not having the medication, they have this psychological satisfaction that they could equate with cure. So they feel that the disease is cured. That brings a lot of happiness to the people and their well-being. So many people then go back, much more into their normal life. As in, for example, there are people who have then chosen to conceive, they have had life experiences that they weren't willing to consider before. So I think, anecdotally, I think it has been a very positive experience. Most people have enjoyed coming off the medication. And obviously, with time, their visits to the hospital will be reduced. They are less concerned about the disease. And I think they are achieving a more normal life than before.
Okay, and finally, will you be implementing this new protocol more or less often in the future?
I'm trying to implement this for all my eligible CML patients. So anybody who is eligible based on the current guidelines, I would implement this protocol for them.
Thank you. And our time is coming to an end, but is there anything else you would like to add?
No, I think the future is bright for conditions like CML, which with the advent of TKI has become more or less a chronic disease. And with this new approach of stopping the medications, we are looking at cure as well. There are other cancers which we cannot say the same about, but advances are happening in all fields of medicine, and I'm hoping that this can be replicated in other cancers as well.
Thank you so much for your time and helping us gain a greater understanding into this area of research. It's been a pleasure talking with you, and I hope that we're able to meet again on perhaps a different topic. So thank you.
Thank you very much for having me, Zahra.